Hi everyone, my name is Max Cantor. I am a physical therapist and the Vice President of Connections Physical Therapy. Today we're going to be talking about attacking arthritis. We're going to be learning about what arthritis pain is, what is arthritis, and what we can do about it in physical therapy. So like I said, we're going to talk a little bit more about the background of arthritis. It's oftenly discussed, not gone into a lot of detail. The reason why I put this presentation together is because I sat through a orthopedist's description about what arthritis is, and they talked a lot about how bad it can get and all the problems, but it really didn't get into what the solutions are or what we can do for it. And so what I really want to focus on today is less about the background of what arthritis is, but get more into the nitty-gritty of what we do for it in physical therapy. Then we'll also talk about an introduction of progression of strengthening, what we do for in physical therapy, how we prescribe, dose, and then progress exercise. So before we get into some of that more fun stuff, I want to talk about what is arthritis. Arthritis is an umbrella term for many different types of arthritis. So we can talk about osteoarthritis, rheumatoid arthritis, psoriatic arthritis. Today we're going to be focusing on osteoarthritis, which is by far the most commonly discussed and diagnosed arthritis or arthroses. But just to make sure that if you're talking about it with a physician, that you know specifically what type of arthritis you're talking about. Today is going to be osteoarthritis, OA. Again, when people hear the term arthritis, this is almost always what they're describing. And so how do we describe arthritis? What is it? From my experience and my background, there are many, many different ways to describe arthritis. How I describe it as a physical therapist to my patients is that it is a normal progressive process that occurs over a period of time. It is a normal process. It's not something that is a disease, or it's not something that is affecting just you. We all deal with it to some extent. Doesn't mean that we necessarily be symptomatic with it. You can see people who have the effects of arthritis when they're 30 years old. You can see it when they're 90 years old, and kind of everywhere in between. And for some people, they don't deal with arthritic pain at all. Even though we all experience it, or we all have some level of arthritis as we age, it does not necessarily mean you need to be symptomatic, and we'll talk about that in just a little bit. And so, kind of, what does that mean, right? It's a pretty vague description of it. So each one of our joints in our body have two bones that come together. On the surface of every bone, when it comes to a joint, is something called cartilage. I describe it as like a smooth ice skating rink. It allows us to move and glide over that surface with ease, no problem at all. So when we're 8, 9, 10 years old, that is a very smooth, fresh patch of ice on an ice skating rink, and so we can do all sorts of activities and have no symptoms, no problems at all. Somersaults, cartwheels, jumping, play sports. Over time, because of the normal activities that we do, that ice skating rink starts to wear down. Just like a regular ice skating rink, it starts to get less smooth, a little rougher, it gets chips in it. And what happens with arthritis is as that cartilage wears down from our normal everyday activity, the surface of the bone underneath it is exposed. And when the bone underneath it is exposed, in response to the normal everyday stress that we put on it, that bone starts to grow, and it starts to grow past the cartilage, and that's when you start to hear of things like narrowing of joint space or bone on bone, because instead of having this space here where there's cartilage in between, the bone starts to grow from both directions as a response to that normal process and normal stress and force. So again, arthritis is the wearing down of the cartilage of the joint, and then in response to that, the bone growth that happens with the normal day-to-day stress. It sounds really bad, but again, everyone tends to deal with it for different stages at different levels of their life. And I really want to make the important point that just because we see it or just because you've been diagnosed with it does not necessarily mean that you are symptomatic or have to be symptomatic for the rest of your life. There's so many people that I've seen in the clinic that say, I have arthritis, my mom had arthritis, my dad had arthritis, I'm doomed, this is going to be my life forever. There's a lot of research out there showing that that's not necessarily the case. And so here, what we're describing is the percentage of people who are asymptomatic with degenerative changes in the spine. And so For the 20-year-olds, 30-year-olds, 50-year-olds, 60-year-olds, these are people who are totally asymptomatic. They have no back pain, no neck pain, no spine pain, no symptoms. But when you take an image of it, either an X-ray or an MRI, there's a very high percentage of people that have quote-unquote degenerative changes. When we get to the hip and knee, the same thing, right? So when we talk about arthritis, most commonly we're talking about hip and knee joints. For people with an MRI, revealed 73% of asymptomatic people had abnormalities in the hip. Now we're not talking about 70-year-olds, 80-year-olds, 90-year-olds. We're talking about the average age for this study was 38 years old. And so even at a very young age, when you take people who are totally asymptomatic and give them a very high definition, high quality image, you are going to see some level of abnormalities or degeneration. In the knee, the same thing. Up to 43% of individuals over the age of 40 showed degenerative changes. So for everyone out there who has had an X-ray, a CT scan, an MRI of their hip and knee, and you've looked at the report, you're going to see meniscus tears, you are going to see arthritis, you are going to see the term degenerative changes. And just because you see that doesn't necessarily mean that you have to be symptomatic or even are symptomatic. So we have to correlate what we see on an image with what we see in the clinic. So when someone comes to me with hip pain, knee pain, and they have a report from an X-ray or an MRI, and I see all these big scary words and the patient and the people I'm working with are scared, I always say, yes, the image gives us information, it gives us background, it gives us an understanding of what's going on in the joint, but that doesn't necessarily doom you for the rest of your life that you have to be in pain or that this is only going to get worse. That's kind of my soapbox speech, because I think so often when we're in the healthcare field, we talk about these pathoanatomical diagnoses and we're just very cut and dry with it, when we know that there are so many people who have terrible looking X-rays, terrible looking MRIs, who have no symptoms at all, or who had symptoms and still have bad looking images but are now asymptomatic. And that's kind of where physical therapy and other intervention comes into it. So you might be asking yourself, why do we feel pain, right? So I'm talking about arthritis, I'm talking about degeneration of the cartilage, I'm talking about bone on bone, all these terms that we've heard about. How does this translate to pain? When that ice skating rink is disrupted, like I described, the underlying tissue, that bone, becomes involved. So normally the cartilage that contacts the cartilage on the other side of the joint there's no symptoms, there's no pain, there's no feedback, right? We don't feel from our cartilage. But when that cartilage is disrupted, the bone underneath it becomes exposed, and when there's contact and normal stress and normal force, like walking, going up and down stairs, that come into contact with that bone, that's when we become that's when we become symptomatic, excuse me. So once we start to expose the tissue underneath that cartilage that is going to give us feedback, that's when we start to feel pain. It often presents itself like the last straw that broke the camel's back. Like I woke up one day, tried to go up and down stairs, and holy moly, it was the worst pain I've ever had. It doesn't mean that necessarily you had arthritis occur overnight. This is usually a slow process that builds up and up and up, but it tends to present itself like a one-time last straw that broke the camel's back activity. So during this presentation and what I've already talked about seems to minimize kind of the arthritic changes in joint pain. And I do that because I think in the healthcare industry we go so far to the other extreme that we talk about arthritis like this doomsday diagnosis, but it really can cause a lot of functional limitation. It really can cause a lot of high level of pain. We see a lot of people who have total hip and total knee replacements because of arthritis. And so I'm not trying to minimize the diagnosis, but what I am trying to do is talk to people about what we can do for it, about being proactive versus just having this passive response like, okay, I have arthritis, someone needs to give me an injection or need to have surgery. We should try to be more proactive about it, in my personal opinion. The symptoms that we see, like I talked about, are pain, stiffness, swelling, limited mobility. You might not be able to bend your knee as much as you were before, or when you try to get out of bed, there's some stiffness, getting in and out of bed. Those can be signs of arthritis. And like I said, we have many people who are asymptomatic with arthritis. So the big takeaways from the first kind of portion of this presentation is that arthritis is an umbrella term. Like I said, rheumatoid, osteo, and psoriatic arthritis are the most common types. Today we're talking about osteoarthritis, which is by far the most common type of diagnosis we see. Probably the biggest takeaway from that portion is arthritis is a normal degenerative change that affects each person differently. Some people get it when they're younger, some people get it when they're older. It is considered a disease process, but it is a normal process that occurs over time from doing our normal day-to-day activities. And like I said, just because we see something on an image does not mean that it needs to be clinically relevant, or does not mean that it's actually causing your symptoms. We need to correlate what we see on a picture like an MRI or X-ray or CT scan to what we're seeing in the clinic. So that's the first kind of background information. Let's take our first deep breath as we kind of process all the information that's coming to you. So what do we do for that, right? So what do we do for arthritis, especially from a physical therapy standpoint? The biggest factor for people who have arthritic changes, confirmed arthritic changes, and have a high level of function and mobility and low levels of pain, why do we see that some people can sustain arthritic changes without pain? And the answer is strength. The strength of our muscles around the joint. So let's kind of break that down. Why does strength play a role in what's happening in my joint? Why does the muscles affect the bones? So when arthritic changes are present, so let's say someone has arthritic changes present, they may know it or may not know it, inflammation can occur. And so the most common story that I hear with people is, I went to go visit my family, we went to go on a vacation, we walked around a ton that day, I felt great, it was beautiful, sunny outside. And then that night I started to feel a little bit of achiness in my knee, but no problem at all. The next day I woke up and bam, my knee was swollen, I couldn't get out of bed, it was red, hot, I had to ice it, I could barely walk up and down stairs. That's kind of that last straw that broke the camel's back type presentation. So what happens in that moment? When we walk a lot or do a change in our normal activity or overstress the joint, the inflammation occurs. So arthritis is an inflammatory process. When inflammation is in the joint or in the area, it inhibits the muscles. So the muscles tend to shut themselves off and turn themselves off. When that happens, the muscles become weak. When the muscle becomes weak, they cannot support the joint during our normal activities. So when I go up and down stairs, my muscles absorb some of that force, my joint absorbs some of that force. If my muscles are strong, they can absorb a larger portion of those type of activities. When my muscles are weak, I have to rely much more on the joint stability, the joint structures. If we have arthritic changes, putting more stress and more force through that joint is going to result in potentially pain and those arthritic symptoms, just like we were talking about before. So kind of the summary, inflammation occurs, muscles become weak, muscles can't support the joint now starts to feel the effect of normal activities that we once were able to tolerate. So the stronger your muscles are around the joint, you're going to have improved pain levels, improved mobility, improved tolerance to normal activity. Think of stairs, walking long distances, getting in and out of the low chair, a low couch. Then you're probably going to have a slower progression of those arthritic changes. So the stronger your muscles are, the less force and stress the joint has to take on. I think of it as like a pie chart, right? So if this portion of the pie chart is your muscle strength and this is the joint, you're doing pretty well, right? The joint doesn't have to do very much on a day-to-day basis. If all of a sudden those muscles become inhibited and this portion is the joint and this portion is the muscle, well, you're going to have a lot more issue, right? Because now the joint has to do all of this activity and all of this tolerance of force and stress, and you're going to start to feel some of those arthritic changes, where if this is the muscle, you're not going to have to do that. So not bad, right? We now have kind of our first and most common intervention when it comes to arthritic pain. If we can get stronger, we can improve our symptoms, we can improve our tolerance to activity, which is ultimately what we're trying to do in physical therapy. So second deep breath. I go through this information relatively quickly. I know it's a lot of information all at once, but what I always want is to take away the big messages. And for that portion, the big message is strength training, and the stronger your muscles are, the better you're going to tolerate the type of activities that you want to do. So the next thing I want to go through is strengthening. So we just talked a lot about what we do for arthritic changes, arthritic pain is getting stronger. How do we do that? So there's some key points on strengthening. Not each exercise and each type of exercise is created equally. So when we're talking about exercise, there's resistance training, think of weights, resistance bands. Aerobic cardiovascular training, think of walking, biking, swimming, running, elliptical. Flexibility training, that might be like a yoga or stretching regimen. And then balance training, certainly something that we work a lot about in physical therapy. Is kind of a different category when it comes to strength and exercises. So today what we're going to talk about, when I say strength training, we're going to talk about resistance training and also consider that postural training. So strength training when it comes to arthritis is really about the resistance training and the postural training. A lot of times I'll see people in the clinic who say, oh, I'm really, really strong. I walk 10 miles a day, or I walk 3 miles a day, or I swim 5 times a day. Yes, you are very strong in a cardiovascular and aerobic capacity, but that doesn't necessarily stress and strain the muscles in the same way as resistance training would. The example I always give is a marathoner versus Arnold Schwarzenegger, right? Those two people are in incredible shape. Someone who can run a marathon and Arnold Schwarzenegger who can lift 1,000 pounds over his head. They're both in incredible shape, but the person who stressed themselves for a marathon, their muscles are not as big and strong as Arnold Schwarzenegger. So the marathoner is kind of that aerobic, cardiovascularly trained person. Arnold Schwarzenegger is more that resistance trained person. To get stronger and to do resistance training, you don't have to look like Arnold Schwarzenegger, but you do have to stress the muscles in that direction of resistance and postural training. And so I always want to make sure that this point is really brought home, that just because you walk, swim, do the Stairmaster or elliptical, doesn't mean that that's the exact right thing you should be doing for your muscle strength and for your arthritic pain. They're fantastic exercises, but it doesn't replace those type of resistance training that we're going to introduce in physical therapy. So like I said, the goal of resistance training is to get the muscle stronger, bigger and stronger. The biggest mistake I see when it comes to resistance training, and we see a lot of this, is that people start at too high of a level. They get it in their minds, they look online and they talk to a friend, they say, oh, you just need to get your muscles stronger, and they start doing these really, really challenging exercises that are going to way overshoot the tolerance and the ability of their current muscles, and that actually pisses off the area even more. So if you're trying to do strengthening of the knee and you start right away with doing squats and high-level exercises like that, it's going to irritate the muscles, it's going to irritate the joint, cause more inflammation, and actually make the problem worse. So a lot of times I'll see in the clinic people say, I tried to get stronger, I tried to go into the gym, and it just made things worse. Why are you talking about strength training? Well, we have to build the foundational muscle strength first. You can't just go straight to the high-level exercises that were more commonly known. We have to break that down to the most basic exercises first. So normally at this time in the presentations when I'm in a community setting is I'll have a volunteer come up and do some of the exercises. Unfortunately we can't do that because we're all appropriately quarantined at home. So I do want to introduce some of these exercises so you can at least visualize it and see it, and I'll talk through some of the basics of exercise progression. But the most important thing to remember is that we have to start from the foundational exercises. Even if you think you're really, really strong and you have a bout of pain or a bout of swelling and inflammation, remember those muscles are inhibited and they're weaker. And so even if you were exercising and strength training for 6 months and then all of a sudden you get a bout of inflammation and swelling and a lot of pain, those muscles are inhibited and we have to build them back up from the ground level. So that's the most common mistake I see in what we're going to talk about here. From a physical therapy standpoint, I like to toot our own horn at this point. this is our bread and butter. This is what we do best: exercise prescription and exercise progression. And so if you're unsure or unclear, this is when working with a physical therapist is really, really beneficial. So this is the fun stuff, right? We're going to go through a progression of each exercise. I'm sorry I can't be there with you to go through it, or that we can't visualize it, but I do want you to at least see some of the exercises on the screen so that you have a sense of what I'm talking about, how I'm describing it. The main groups that we usually talk about are the arms and trunk, the core, and then the legs. And so if you're dealing with knee and hip arthritis, which is the most common, we're going to be focusing a lot on core and legs. We often can see some shoulder arthritis or even some thumb arthritis. So we are going to focus, at least introduce some exercises, more full body, just so you guys can have a sense of what type of exercises that I'm just talking about, or that I would be introducing with a patient that I'm working with. Like I said, strength training is the most effective conservative intervention. We're not going to talk about a lot more of the medical interventions like medications, injections, surgeries. I like to leave that for the orthopedist. It's something that we're well versed in. But today, really, I wanted to talk about some of the least invasive, more conservative approaches first today, because that's the progression you should be going through, not just jumping straight through surgery to medication or to an injection. It's important, it's also kind of a disclaimer that I like to go through right now, because I'm not with anybody right now and because you're seeing this from home. Strength training should not be painful. It should not cause any problems for you. If you're not sure, or if you've not done a lot of resistance or strength training exercises, I highly encourage you to work with a physical therapist first. Not knowing what you're doing can cause a lot more problems than benefit, and just working with someone who knows what they're doing can get you on the right track, and then you'll be able to transition to an independent home program. But starting this on your own, if you've never done anything like this before, especially if you're already in pain, is not something I recommend, and you should always consult with your primary care physician before starting any sort of exercise program to make sure that it's appropriate for you. So the first thing we're going to go through is the back muscles. Again, I can't demonstrate these right now, but these are some of the pictures that I would give with some of the exercises. What you'll notice for a lot of these is that there's level 1, level 2, and some of the other exercises there's level 3 and 4. This is where I would start with someone, and then by the end of it, or middle to end of the program, I'm going to be starting to get to some of the higher level resistance training type exercises where there's actually band resistance to it. This is just to wake the muscles up right here. Say, hey muscles, remember this is how we should be working. Try to find the muscles and get them going, and then as we get to the more resistance bands, that's actually getting the muscles stronger. This is for our rotator cuff, so people who have arthritic changes or pain in the shoulder. These are some of the rotator cuff strengthening exercises, some of my favorite for any sort of shoulder blade or scapular pain that people are experiencing. Arm and muscle, biceps, triceps. Not a huge portion of people with arthritic pain are dealing with elbow problems, but again, I thought I would introduce it, or at least show the pictures. Forearm muscles, although again, not very common, we do see a lot of people with thumb pain. So a lot of people who can have symptoms, or arthritic symptoms right here, is called basal arthritis. That's where the bottom of the thumb is causing some of the symptoms down here. So strengthening the forearm and the hand with some of these exercises can be really beneficial. It's not a muscle group that we often think about in physical therapy, but if you're having trouble with typing, writing, gripping, opening doors, and you're getting a lot of pain down into this area, you might be having some arthritic changes in that specific joint. These are the type of strengthening exercises that we'd be doing to focus on that specific area. So core muscles are going to be a really important one as well. This is someone who may be dealing with arthritic pain in the spine or in the hips. These are some of the more challenging exercises to conceptualize just based on pictures. Core strengthening and core training is one of the more difficult muscle groups to engage appropriately and to educate on. I can spend 2-3 sessions just focusing on with the patient how to strengthen the muscle, how to turn on those muscles. Once they get it, but it's usually a pretty foreign concept for people that I'm working with. So this is kind of the more basic exercises here, and then you can see some of the arrows you're going to progress through, and then here are some of the more challenging, higher level exercises. that you would be getting into in physical therapy. There are hundreds of different exercises that you can introduce and provide to someone for core strengthening. These are just some of the ones that I would give each person that I work with, depending on their exercise ability or kind of neuromuscular ability. I would be catering specifically towards you for what exercises to prescribe. We're going to get into the legs now. I broke it down by muscle groups, so the quadriceps are the front of the thighs here. These are the most common exercises I give because, again, the most common type of arthritis is in the big joints in our legs, the hips and the knees, sometimes in the ankle. These are some of the more common exercises that people have seen, so you may have seen these type of strengthening exercises for the quadricep. This is for the glutes. Again, we have level 1. You can notice it's a bed level exercise. You're lying down. I never have people get on the floor. You can do it on a couch or in the bed. No reason to get on and off the ground. And then you're progressing towards standing, and then you're progressing towards standing with resistance bands. And so what I'm always focusing on is the foundational strength, and then quickly trying to progress people towards a functional activity. Because what we really ultimately want to be able to do is walk better, stand better, get in and out of a chair better, go up and down stairs better. So if all you're doing is bed level exercises, well, you're only going to strengthen the muscles in those type of functional positions. You have to transition to higher, more functional level exercises to translate to what you want to be able to do on a day-to-day basis. Same thing with the groin adductor muscles. We're going to be getting into higher level strengthening exercises. Hamstrings, back of the thigh. Again, you'll notice lying down, standing up. As we get to the higher, more appropriate exercises. Once you've built that foundation, you're progressing towards that higher exercise. Lower leg, calf, ankle strength, a big muscle group for walking. People often forget about this muscle group when it comes to arthritis, but people who want to walk better need to have good calf strength. So the big takeaways, my goal for today is to kind of give you this foundation of knowledge. Why are we doing strength training when it comes to arthritis? What is my first instinct, my first level of intervention when it comes to arthritic pain? Now that either it's been diagnosed or you become symptomatic, strength training is a big portion of it. That's the least invasive, most appropriate conservative approach when you're first dealing with this type of pain. When it comes to strength training, listen to your body. We always want to have a long-term sustainable exercise program. So if you're doing something and when we get into the gym or we start a program, we get all excited, we get all energetic, and we shoot for the moon and we come crashing back down 3 days later. Especially when it comes to physical therapists, we want to give sustainable exercise programs, meaning that you don't do it for 2 days, 3 days, and then you fall off. You have to be doing it for weeks and weeks to months and months. So there are going to be days that you can't do as much as you did the day before, or your muscles are a little bit more fatigued and tired, or you need to take a day or two off. That's perfectly fine. I would much rather do the slow and steady approach than kind of come sprinting out of the gate and fatigue and overdo it too quickly. We need to listen to your body, especially when someone's in pain or there is an underlying arthritic changes. We need to listen to how your body and muscles responding. Again, that's why if you've never done this before, you never have done sort of resistance training exercises, it's important to work with someone who knows what they're doing so that they can instruct you, educate you on, yes, this is normal to feel after exercise, or no, I don't want you feeling that, we need to back off the intensity of the exercise program. It's also important to remember that no exercise should be painful. Especially when we're dealing with this type of exercise program, it's not a no pain, no gain situation. You hear that term all the time. It's kind of this mentality that people get into that if I just push through it, I'll get better faster. If you try to do that, your body and the arthritis is going to win. It's going to ultimately cause more inflammation. It's going to cause more muscle inhibition. It's going to cause weakness of the muscles, which is ultimately going to cause more pain. That's what I hate to see, is when people are putting the time and effort into it, but they're not doing it appropriately, so that they're actually just walking backwards, or they're working backwards. Slow and steady is definitely going to win it. Focusing mostly on mechanics and consistency, that's going to get you the best results long term. So like I said, don't put yourself at risk for further pain. If you're not sure, ask your PCP if physical therapy is right for you, or talk to a physical therapist. it's important that you are putting yourself in a position to succeed. And so it's important to talk to your primary care physician or physical therapist, especially if you haven't done a type of exercise strengthening program like this before. The worst thing you can do is put the time and effort into it and then go backwards because you are overdoing it or not doing the exercises correctly. Working with someone like a physical therapist can get you on the right track and then progress you to doing a independent home program once you build the foundation and you have a good understanding of what you should be doing long term. This is our bread and butter as physical therapists. We are really good at prescribing and progressing exercise, and then also educating on the right mechanics and form of those specific exercises. We're also good at educating and informing you so that you are able to independently progress and maintain and manage your symptoms or your exercise program. So like I said, this is a pretty weird time. If you're stuck at home and this is resonating with you, or you want to start dealing with some of the symptoms that you're dealing with or the pain that you're having, give us a call, let us know. We are able to provide telehealth services, meaning that we can either have a phone call or a video conference where we can see you, talk about your symptoms, evaluate you, and then provide exercise intervention. There's a lot of people who aren't able to do as many activities as they once were, or they're not able to stay as active because they're stuck at home or not able to get out and about. This is the perfect time to be trying to maintain and take care of yourself. And if you're not sure, haven't done this before, make sure you're getting that guidance from us and from a physical therapist. Here's the contact information. Like I said, you can give us a call or send us an email to start that. And if you're not sure, just give us a call anyways, and we'll talk you through whether physical therapy is appropriate for you or telehealth service is appropriate for you. So thank you very much for watching today. I'm sorry that we weren't able to all be together. I like to get out in the community and meet people, talk to people, and demonstrate while I'm there. Unfortunately, we're not able to do that right now, but I can't wait for the day where we're able to get back out and work together in the communities. Like I said, my name is Max Cantor. I'm a physical therapist and vice president at Connections Physical Therapy, and thank you very much for watching today. Thank you.